Okay, just going to give a few minutes for the attendees to sign in. Good morning. Happy September 1st. I'd like to welcome everybody to this year's first grand rounds of this academic year. Today we have three of our internal medicine chief residents presenting a grand rounds on long COVID. We have Brian Lauzon, Palki Bhatt, and Christina Ma. All three of them are our chief residents here at the Hamilton General Hospital currently, and I'd like to welcome them to give their presentation on long COVID. Thank you.
Thanks so much, Dr. Panju, for that introduction. Hi, everyone. My name is Christina, and together with Palki and Brian, we are very excited to be presenting grand rounds to you today. As Dr. Panju said, we are all PGY3s in internal medicine, and our faculty advisor is Dr. Haroon Yousuf. Sorry, I apologize in advance. I am currently post-call / on-call, so I'm sorry if my pager goes off throughout the presentation. So like I said, our faculty advisor is Dr. Haroon Yousuf, so we'd like to thank him as well. Our presentation today is entitled Long COVID, What We Need to Know About Post-COVID-19 Conditions. So to start off, we'll be doing a land acknowledgement. We take this time to recognize that we are currently on the traditional territory shared between the Haudenosaunee Confederacy and the Anishinaabe Nations, which was acknowledged by the Dish with One Spoon Wampum Belt. So our objectives for our talk are as follows. Firstly, we are hoping to provide an overview of the condition known as long COVID, to describe the prevalence and suggested pathophysiology of long COVID, to review the clinical presentation and approach to diagnosis, and finally, to review the evidence for treatment of long COVID syndrome. So to start off, I thought we could take a little bit of a bird's eye view of our understanding of post-COVID conditions and look at where we started and look at where we've now ended up. So we start at March 2020, and I don't think I need to belabor the point of what happened in March of 2020. That's really when the global pandemic started and all of us started to become introduced to COVID in general. At that time, we were mostly seeing the acute sequelae of COVID. Interestingly, the first time the word long COVID was introduced to the world was actually shortly after, a couple of months later in May of 2020. And long COVID was actually first described by patients and was first described on Twitter by patients. And social media was a way for patients who were having shared experiences of persistent symptoms after their acute COVID had resolved to come together and explore what was going on and advocate for themselves. The first time that I could see that COVID was real, or post-COVID conditions were really talked about in the medical literature, was a few months later in July 2020. An Italian group was the first to comment on a group of hospitalized Italian patients who were having symptoms several weeks after their acute COVID infection. There was also an article in the BMJ around July 2020 describing a patient's clinical course with presumed long COVID. The medical community came together and was actually quite quick in creating the first sort of set of guidelines. And that occurred in December 2020 via the UK's NICE rapid guidelines. And these were the first guidelines ever to discuss the long-term effects of COVID-19. From that time on, more research started to develop, and we'll talk about some of that research today. And various different definitions of what post-COVID conditions or long COVID were introduced by varying different groups across the globe. In October of 2021, the World Health Organization finally created a clinical case definition, which is now the most widely sort of accepted definition of what a post-COVID condition is. So the WHO clinical case definition was developed via a prospective Delphi consensus-seeking exercise. A mixed iterative survey was sent out to a wide group of stakeholders, including internal and external experts, as well as patients. And the results of this survey was used to create the clinical case definition. So it reads, post-COVID-19 conditions occur in individuals with a history of either probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID-19, with symptoms that last for at least 2 months and cannot be explained by an alternative diagnosis. Common symptoms include fatigue, shortness of breath, cognitive dysfunction, and also others that generally have an impact on everyday functioning. Symptoms may be new onset, following initial recovery from the acute infection, or they can persist from the initial illness. Symptoms may also fluctuate or relapse over time, and a separate definition may be applicable for children. As you can see, this clinical case definition is quite broad and can encompass quite a heterogeneous clinical syndrome, which will again come up over and over again throughout our presentation. So the term post-COVID-19 condition is really the umbrella term that we'll be using to include the variety of different terms that have been thrown about both colloquially and in the medical literature about this sort of post-COVID syndrome. These include things like long COVID, chronic COVID, PASC, which stands for post-acute sequelae of SARS-CoV-2. And this term will be used throughout our presentation. There's also a variety of associated conditions that are often associated when we hear the term long COVID or post-COVID conditions, but these conditions don't strictly fall under the WHO clinical case definition. These include things like post-intensive care syndrome, complications of acute COVID infection, including things like thromboses, and new autoimmune conditions that develop post-COVID, such as a new diagnosis of inflammatory arthritis. Though these are definitely relevant conditions, in order to narrow the scope of our presentation, we wanted to follow more strictly the WHO clinical case definition, as this is what's most commonly used in the literature and other research studies. So the pathophysiology of long COVID is really not well elucidated. There are a few theories that have come about based on our understanding of COVID and other viral illnesses, as well as some basic research that has come out thus far. What we believe is that it's probably a multifactorial pathology. And the most common 3 prongs that have been brought up are a delay in resolution of inflammation, a potential persistent viral reservoir, and triggering of autoimmunity. From the delay in resolution of inflammation perspective, there's been multiple studies showing a persistent increase in various inflammatory cells and inflammatory mediators, such as monocytes, neutrophils, dendritic cells, effector T cells, and various inflammatory cytokines. These have been noted weeks to months after the acute resolution of COVID. There's also noted to be reduction of tissue-resident macrophages, which can alter immune homeostatic mechanisms. A persistent viral reservoir was thought to be existing in ACE2 expressing organ groups, such as the central nervous system and the GI tract. Some studies have showed that biopsies of intestinal enterocytes, again, weeks to months after the acute COVID infection, still show COVID proteins. And there's also evidence that memory B cells in patients with long COVID show persistent clonal turnover and greater somatic hypermutation. And finally, in terms of triggering autoimmunity, it's been long known that induction of autoimmunity from other viral illnesses is possible. And it's thought to believe that COVID could cause a similar phenomenon via similar mechanisms, including viral mimicry, breakdown of tolerance of self-antigens, and epitope spreading. So the prevalence of COVID, of long COVID or post-COVID-19 conditions is extremely varied. And there are a variety of studies with very heterogeneous findings from all across the globe, all across different time periods. Prevalence estimates vary from anywhere as low as 2 to 80, anywhere as high as 89%. The challenges with assessing prevalence include that different research studies are using different definitions. There's no clear diagnostic criteria. There's differences in reporting of symptoms, whether it's doctor documented or self-reported. There's differences in COVID testing and availability of COVID testing. So different research studies are using, PCR confirmed COVID versus rapid COVID tested versus probable COVID, but no clear testing done. And finally, there's a very heterogeneous spread of severity of COVID infection. The most recent systematic review that I could find was from April 2022. And this slide is really capturing the variety of different studies that they included. What I really wanted to highlight here is just how heterogeneous it is. As you can see, the lowest estimate is around 9%, and the highest estimate is up to 83%. So really quite a varied spread. Moving into more specific groups. So from this systematic review, the prevalence across all studies was 0.43. And there seemed to be an association with decreased prevalence in non-hospitalized patients with a prevalence of 0.34 and an increased prevalence in hospitalized patients with a prevalence of 0.54. From a geographic perspective, there was a slightly higher prevalence in both Asia and Europe at 0.51 and 0.44 respectively, and a slightly lower prevalence in the USA at 0.31. And there was a slightly higher prevalence in females at 0.49 compared to males at 0.37. An interesting thing to note is the prevalence in vaccinated populations. This is still an area that needs more research. But a new study in July of 2022 from an Italian group looking at the effect of vaccination on prevalence in non-hospitalized healthcare workers with COVID seemed to show that there is an association with increased prevalence in patients who were unvaccinated. So you can see here the prevalence was 41.8% in the unvaccinated group and as low as 16% in the 3 vaccine group. Of course, this was just one study. I couldn't find any printed systematic reviews, but there is a preprint living systematic review that showed any dose of vaccination associated with an odds ratio of 0.85 to 1. Unfortunately, there is very high heterogeneity between studies. There was only 4 observational studies. No trials obviously have been done, and there's a very low certainty of evidence for this. Moving on into the clinical presentation, as I previously described, it's a very heterogeneous syndrome and can present with really any symptomatology. The most common ones from head to toe include cognitive symptoms such as brain fog, as well as impaired sleep, psychologic symptoms such as anxiety, depression, altered taste and smell. There is also often cardiopulmonary manifestations, including chest pain, palpitations, dyspnea, and cough, as well as autonomic symptoms, including a POTS-like syndrome. Fatigue is a very common symptom. And then there's also less common, but certainly clinical syndromes around the GI system, including abdominal pain, abnormal bowel movements. There's often arthralgias and myalgias that go unexplained, and neurologic symptoms, including paresthesias. Based on a systematic review, these are the most common, or the symptoms with the highest prevalence. Fatigue at 25%, shortness of breath at 18%, cognitive impairment at 20%, smell dysfunction at 30%, insomnia at 22%, and anxiety at 32%.
Okay, so now I'm going to be talking a little bit about the symptoms that are seen in long COVID, along with how we assess them and how we manage them. And I'm going to start off by talking a little bit about the NICE guidelines. So NICE is the National Institute for Health and Care Excellence, and it's coming out of the UK. And that's essentially, as Christina mentioned, our main form of guidelines that we have internationally. It's a living document that's updated fairly frequently with new evidence as it comes. And so the best way to approach sort of our understanding of the symptoms is through like a system-based approach. So I'm going to start off by talking about some of the cardiac and pulmonary symptoms that present with long COVID. So from a cardiac perspective, the most commonly reported symptoms were chest pain, ongoing chest tightness, as well as palpitations. And from a respiratory perspective, patients tend to have cough and breathlessness. And those are really, out of all the cardiac pulmonary symptoms, cough and breathlessness have been the most commonly reported symptoms among patients with long COVID. So the NICE guidelines make some general recommendations about how to assess and investigate patients that have cardiopulmonary symptoms. And as Brian and I talk about some of the symptoms that present with long COVID, you'll notice that sort of the overlying theme is that patients should essentially be assessed, investigated, and managed as you would in any patient, whether or not they had acute COVID. So there are really no specific management strategies or assessment strategies for patients just because they had acute COVID in the past. It's essentially how you would typically manage any other patient. So starting off with sort of the cardiac stuff, the strong recommendations from the NICE guidelines essentially say if a patient is having orthostatic symptoms, they would recommend getting a set of postural vitals to identify that. And of course, they make strong recommendations that patients should be referred to acute care if they're found to be hypoxic, if they have evidence of severe lung disease or evidence of cardiac chest pain. So those are the strong recommendations from the NICE guidelines. They do make a number of conditional recommendations for patients in specific scenarios, and they leave it to the clinician's judgment to determine if those investigations need to be done. So that includes things like routine blood work, a BNP in certain scenarios, a CRP, a ferritin. In terms of imaging, the one recommendation they make conditionally is getting a chest x-ray on patients if they're having ongoing respiratory symptoms by the 12-week mark. In some patients, they recommend exercise tolerance tests, and they do make quite a bit of discussion about supported self-monitoring at home. And so in the NICE guidelines, they talk quite a bit in detail about counseling patients about how they can monitor their symptoms at home, getting them ambulatory blood pressure cuffs and home oxygen saturation, how to record their symptoms, and when to present to emergency. So the NICE guidelines don't have, as you can see, very specific ways of assessing or investigating, but thankfully there are some other sources that can help us sort of manage the cardiac symptoms. So the Canadian Journal of Cardiology in 2021, August, came out with this primer from the CCS Rapid Response Team that essentially helps us understand how to approach patients with long COVID that have some degree of cardiac symptoms. And so they go through some of the main symptoms that we mentioned sort of throughout this talk, which are chest pain, palpitations, and symptoms of orthostasis. So they essentially say if a patient is presenting with chest pain, again, evaluate them as you would with any other patient. In a patient that's had a history of COVID, you just want to rule out things like myopericarditis and ischemic heart disease. And those could be done according to the CCS guidelines with an ECG, a trope, in some cases an echo, and in some cases a functional test. Again, very similar to how we would approach really any patient with chest pain. If someone is presenting with palpitations, the etiology could be something like an arrhythmia, inappropriate sinus tachycardia, and cardiac dysautonomia, which has been seen in a number of patients that have had recent acute COVID infections. Those are investigated with an ECG, Holter monitor, as well as an active standing test. And finally, one of the other commonly reported symptoms is orthostasis, which could be indicative of cardiac dysautonomia. And so those patients should, again, as the NICE guidelines suggested, get a set of postural vitals and can undergo an active standing test for definitive diagnosis. In terms of management, the CCS guidelines talk about sort of these three categories of cardiac disease and comment on how those can be managed. So if you do those investigations and you find that the patient does have myocarditis, the treatment is very similar or the exact same essentially to what how we would treat a patient with myocarditis, whether or not they had that COVID infection. So that would be with the use of NSAIDs or colchicine. If a patient is confirmed to have some degree of cardiac dysautonomia, The CACS guidelines recommend things like hydration, salt supplementation, compression garments, and in certain situations, we do use pharmacotherapies such as midodrine or ivabradine. And if the patient is, after investigations, found to have established cardiovascular disease, they recommend, in general, guideline-based goal-directed therapy, which is essentially what we would do regardless. Now, from a respiratory perspective, we don't have sort of clear guidelines, Canadian guidelines yet. They are in the process, but we have a good set of European society statement on how to follow up COVID. And the Canadian Thoracic Society actually put out some nice recommendations about the use of pulmonary rehabilitation in patients with persistent COVID symptoms, persistent respiratory COVID symptoms. So looking at the symptoms that patients typically present with, and as you remember, I mentioned dyspnea and cough tend to be the more commonly reported symptoms that are persisting. In terms of dyspnea, literature shows us that it can last for quite some time, 6 to 9 months. It can take to improve after the acute phase of the COVID infection. And the general consensus amongst all these, all the guidelines and literature is essentially trying to investigate and address the underlying reason for the dyspnea. So they should have stand-up workup if you're suspicious of a pneumonia, whether the patient has deconditioning or some sort of neuromuscular weakness, and they should be treated as you would in any other scenario. For example, if a patient's presenting with dyspnea, you get some imaging and they're found to have an organizing pneumonia, they should be treated with oral corticosteroids as you would in any other situation. And they're still working on sort of developing some more evidence if they're about the use of our sort of standard treatments for any of these conditions. And then cough is, again, this is probably something you hear a lot about, persistent cough lasting months. We don't have quite a good sense of how long the cough can last, but essentially all the literature says supportive therapy is our mainstay of treatment and the use of over-the-counter cough suppressants. The big question a lot of people have is about imaging for patients presenting with respiratory symptoms. And so the recommendations from the NICE guidelines, as well as most of the other literature, suggests you really only need to get chest imaging, so a chest x-ray, if there was noted to be a prior abnormality during the acute phase of the COVID infection, or if they have new respiratory symptoms. So if you don't have any imaging at all, a chest x-ray should be ordered at around the 12-week mark if they have persistent respiratory symptoms. And then they do suggest, further imaging like a CT scan if initial imaging suggests that there may be some other pathology. So if there is some suspicion of a malignancy or underlying ILD or fibrosis, up to the clinician's judgment, they can order advanced imaging. And in terms of the timing of sort of resolution of post-COVID lung changes, the literature shows us that, the findings could take 2 to 4 weeks to resolve typically. It can take up to 12 weeks, and there is quite a bit of literature coming out that it can take up to a year for the radiographic findings to improve. So here is just a progression of chest x-rays of a single patient with COVID. The first x-ray is from day 6 of their acute COVID infection, and the last is from day 28. So as you can see, there are some persistent findings on chest x-ray, which is not entirely atypical in COVID patients. And the last thing I wanted to talk about was pulmonary rehab. So I showed you the title of the Thoracic Society, Canadian Thoracic Society guidelines on pulmonary rehab. And they do provide some pretty strong recommendations about all patients with respiratory symptoms should at some point get evaluated for their candidacy for pulmonary rehabilitation. And these are sort of the criteria they suggest for when a patient should be referred to pulmonary rehab. And so that's if they have new or ongoing respiratory symptoms from their initial infection along with functional limitations. And then if they have on top of that a need for supplemental oxygen, persistent radiographic abnormalities, or an abnormal PFT, they should be recommended for pulmonary rehab, and the efficacy is being evaluated right now in studies.
So we're going to change gears a bit now that we've talked about the cardiac and pulmonary manifestation of post-COVID-19 conditions, and talk about some of the neurologic and other manifestations that are associated. So starting with the neurologic sequelae of post-COVID-19 infection, like most conditions, this can be divided into both acute neurologic manifestations that occur primarily as a complication of acute COVID-19 infection, which is less in keeping with the WHO case definition that Christina mentioned earlier. And then persistent neurologic symptoms that are unrelated to these acute complications and can be persistent after that 2 to 3 month mark that's included in the case definition. So in terms of the acute neurologic manifestations, which I'll touch on briefly, so of course, this can include, especially in hospitalized or critically ill patients, delirium or persistent encephalopathy, neuromuscular disease. So there's an association with COVID-19 with Guillain-Barré syndrome, as well as for any critically ill patients, they could have critical illness related polyneuropathy. Cerebrovascular disease such as stroke is one that's received a lot of attention in the literature. So there is an odds ratio between 2 to 3 of acute ischemic stroke in patients 1 to 3 weeks after their initial diagnosis of COVID-19. And so there is, prothrombotic, pro-inflammatory state that does increase risk of stroke in these patients. And one study actually found that in hospitalized patients, the odds ratio for having an in-hospital stroke, whether you're COVID-19 positive or not, was actually 20.9 for patients who were COVID positive. And this kind of fits with the timeline of stroke occurring between 1 and 3 weeks after the initial diagnosis. So if patients are still hospitalized during that time, that may be why we're seeing that. And then other acute neurologic manifestations that have been described, and once again, more common in hospitalized and critically ill patients, would include meningoencephalitis, seizures, myoclonus, and a variety of others. To switch gears to some of the persistent neurologic symptoms that have been described post-COVID-19. So these are quite varied as well, and some of them tie into the cardiac and autonomic manifestations as well, such as orthostasis or dysautonomia. But others include persistent anosmia, abnormal taste, cognitive dysfunction or impaired concentration, which is sometimes described as brain fog, sleep dysregulation, including insomnia. Headaches are other common ones, as well as numbness and paresthesias. And in one study that followed 270,000 patients post-COVID-19, the overall prevalence of persistent neurologic symptoms that are unrelated to these acute neurologic complications of COVID-19 were up to 37%. So they are quite varied and commonly seen. So similar to the cardiac and pulmonary manifestations post-COVID-19, neurologic symptoms should be investigated similarly to how you would in the absence of COVID-19. And a lot of this can be focused on differentiating between, is this part of the post-COVID-19 syndrome versus are we seeing sequelae of an acute complication of COVID-19? So for example, if a patient is presenting with neurologic symptoms and they're found to have any evidence of a focal deficit on physical exam, then neuroimaging should be pursued, for example, to rule out an ischemic stroke, which could have occurred as an acute complication of COVID-19. If patients are having persistent paresthesias or sensory complaints, then consideration could be given to nerve conduction studies or EMG. And if you're seeing persistent cognitive dysfunction, impaired concentration, then like other patients, you can pursue screening, for example, with the Montreal Cognitive Assessment, and further neuro and psychological testing as indicated. So there can be some effort made to differentiate between whether this represents a post-COVID-19 condition or whether we're seeing the sequelae of an acute neurologic complication. So this could either be persistent weakness post-stroke, persistent deconditioning, muscle weakness from critical illness or polyneuropathy, or otherwise. So in terms of management of acute neurologic complications that are persistent post-COVID-19, similar to previous, the management will be similar to those without COVID-19. So as Palki touched on earlier, if there's concern for autonomic dysfunction, then it's mainly supportive treatment, compression stockings, hydration, other non-pharmacological management, in consideration of therapies like midodrine, persistent neuromuscular weakness, management of the underlying condition, as well as rehabilitation. For patients with stroke post-COVID-19, like other patients, they should undergo a comprehensive workup for the etiology of the stroke. For example, you would still go through comprehensive screening for anticoagulation, since that will impact your long-term management of these patients, and consideration can still be given to all the same hyperacute and acute therapies for stroke for patients with COVID-19 versus without. And then to touch briefly on delirium. So this is more so in the realm of acute complication of COVID-19. But for patients with persistent delirium or encephalopathy, even after resolution of their acute illness or ICU stay, for example, it's usually standard of care as previously discussed, but there have been some case series that have trialed glucocorticoids like pulse methylprednisolone or even Plex in these patients with variable success. But as before, there's no high quality data or really anything above a case series to describe anything more than usual care in these patients. To change gears and chat a little bit more about fatigue, which is one of the more common symptoms post-COVID-19. So fatigue during a viral illness is very common. However, for patients with post-COVID-19 conditions, this fatigue is long lasting, so over that 2-month threshold that we touched on earlier, and usually it's debilitating, so it has a significant functional impact on either a patient's ability to function in their day-to-day lives or on their quality of life. So in one systematic review that examined the issue of fatigue specifically, that included 68 studies and 25,000 patients, they identified fatigue as a persistent symptom after COVID-19 infection in about 32% of their study population. And this was at the 12-week mark post-COVID-19 infection. Perhaps not super reassuringly, when they extended their window to 12 months post-COVID-19 infection, fatigue was still identified as a significant symptom, and they defined that as having some sort of impact on patient-reported quality of life in 31% of the population. In terms of workup of patients who are complaining of fatigue post-COVID-19 infection, as before, workup for the usual things that you would do in patients who are presenting with fatigue. Some more specific guidance that's provided from the NICE guidelines, as well as the American Association of physical medicine and rehabilitation would be to screen for polypharmacy, which may be contributing, and for concomitant psychiatric conditions that may be playing a role, as psychiatric manifestations post-COVID-19 infection are incredibly common as well. And then management of those psychiatric conditions and polypharmacy as per usual standards. And then in terms of biochemical workup, and the items that are listed below are some recommendations from the NICE guidelines. So generally, everyone should be screened at least with CBC, liver and renal function, thyroid function, as well as a ferritin. And then more specific workup can be directed based on the specific presenting complaints. So consideration can be given, for example, to a BNP for patients with cardiac symptoms, morning cortisol, or inflammatory markers. For example, if there's a concern for a new autoimmune condition post COVID-19. Consideration can also be given to exercise tolerance tests to get a more objective marker of the impact of fatigue on daily functioning. So some examples would be like a 6-minute walk test or a 10-meter walk test, which both essentially screen for patients' exercise tolerance. In terms of management of fatigue post-COVID-19, so there's not a lot of high quality evidence that goes into this specifically. The most recent guidance comes from the American Academy of Physical Medicine and Rehabilitation, who posted a consensus statement from 2021 outlining some recommended management for fatigue post-COVID-19. So there are no high quality randomized control trials or systematic reviews that outline management of fatigue post-COVID-19. And this is primarily expert consensus. So these are some of the tenets that they recommend in terms of managing these patients. And some of them are more self-explanatory than others. So for example, ensuring that patients are having adequate rest, hydration, nutrition are all important, as well as reinforcing sleep hygiene techniques, which all may contribute to fatigue post-COVID-19. One of the main things that they emphasize in this consensus statement are principles of energy conservation. And there are lots of different strategies that are described for this, and many have online patient handouts that you can provide to patients that help to reinforce some of these techniques. But one of them that they mention is the 4 Ps, which are planning, pacing, prioritizing, and positioning. And essentially the aim of this is, as the slide says, energy conservation. So pacing or planning involves basically outlining your week and looking at which activities need to be completed and structuring the week around what is most important to get done. So the prioritizing aspect of things, and when is the most ideal time to complete these activities. So if patients know that an activity is going to be particularly strenuous or take a lot out of them, then shifting that more to the evening time when they're able to rest afterwards would be one recommendation. And then pacing and positioning kind of tie into one another. So pacing just basically involves breaking your activity into smaller tasks and taking frequent breaks throughout. And positioning basically outlines things that you're able to do either, say, in a seated as opposed to a standing position. You should take advantage of that. So they talk about brushing your teeth or skincare, that sort of thing. If you don't have to stand to do those things, then you could sit. And the whole principle of the energy conservation techniques are to adapt a structured return to activity program. And so what this involves is patients progressively increase the activity that they're able to do over weeks to months, aiming for submaximal exertion at each point. And you can outline with patients how to kind of monitor their level of exertion, either through objective markers like using, for example, their heart rate or Apple Watch, or standardized scales that outline kind of their symptoms after an activity. And the idea is that with maximal exertion, then that tends to be more fatiguing for patients. They tend to require a longer break or period of rest afterwards, and they're less able to complete tasks and activities after completing an activity that required maximal exertion than they would otherwise. So if we're progressively aiming for submaximal exertion, then there's more energy conserved to build up exercise tolerance. There are some more structured rehabilitation programs that are primarily outpatient that focus on a lot of these principles. And they're mainly staffed by physiatrists. So I know in Toronto, there's a post-COVID-19 clinic that we have referred some patients to that focuses more on the rehabilitation aspect of this and offers a little bit more structure to the principles that are outlined in the slide. I don't believe at this point that there's a specific clinic for this in Hamilton, but correct me if I'm wrong. And then finally, in terms of pharmacologic therapies, so there's no specific recommendations in terms of post-COVID fatigue or poor exertional tolerance, though some literature has suggested that use of agents that have been used in other conditions like fatigue related to multiple sclerosis, Parkinson's, like modafinil or methylphenidate may be beneficial, though right now, as far as I could see, there's no patient-related data available for that. So there's no specific recommendations for that. So in essence, just to summarize some of the key points that we chatted about today. So post-COVID-19 conditions comprise a heterogeneous collection of symptoms that persist at least 2 months from acute COVID-19 infection and overall have an impact on patients' daily functioning. Prevalence estimates are varied, and that mostly relates to case definition and study design, but vaccination may be associated with a decreased prevalence of these post-COVID-19 conditions. And treatment at this point is primarily supportive, aimed at rehabilitation. And of course, one of the big themes that we've had is to approach these patients in a similar fashion that you would for patients presenting with similar symptoms without the COVID-19 aspect. But certainly more research is required to elucidate more directed therapies. And thank you all for joining us today.
Thank you, Brian, Palki, and Christina. If there's any questions, please feel free to raise your hand or put it in the Q&A panel or the chat, and we're happy to answer any of these questions. And just while we're waiting for the questions to come in, I have a quick question I wanted to ask. Looking at your data, it shows a lot of the long COVID over the past years. Have they differentiated between the different strains of COVID, whether it be Alpha, the original, Delta, and now the Omicron? And if the symptoms of long COVID have been different pre and post vaccination and in the different strains?
So there has been some studies on the different strains. There was a recent study done comparing Omicron and Delta, actually, showing that Omicron had a slightly lower prevalence, I believe, and that was independent of vaccination. And then we talked a little bit about vaccination, like pre-onset of acute COVID. I think there was only one study looking at whether or not vaccination post-acute COVID had any impact on long COVID symptoms. And I believe there was potentially some small association with decreased prevalence, but really like not enough high quality evidence to say for sure.
All right, thanks. Dr. Jones has a question. How is this different from chronic fatigue syndrome?
Yeah, so there's definitely a lot of overlap between post-COVID-19 fatigue and chronic fatigue syndrome. So in the American PMR Academy guidelines, they do recommend as well screening for patients to see if they meet the specific diagnostic criteria for chronic fatigue syndrome. And then if they meet those diagnostic criteria, then to manage patients similarly, although the management of both those conditions does overlap quite substantially, but not all of the patients with the post-COVID-19 fatigue necessarily meet the specific diagnostic criteria for chronic fatigue. So it's, I guess, a little bit more broad in its case definition.
Okay, I'm going to go to a few of the Q&As that have been asked, and then a few people have raised their hands. But first, Dr. Yousuf, you just wanted to make a comment?
Oh, yeah, I just wanted to mention also that in the workup of these patients, in the post-COVID, long COVID setting, you do have to also rule out a lot of the other autoimmune sequelae that were mentioned earlier, things like cough, polyarthritis, all of that, which typically in chronic fatigue, you don't have to. So the medical workup tends to be more broad in the beginning. But I do think there's a lot of overlap in management.
I'm going to put two of these questions together, and then we'll go to the live questions. What about psychiatric issues? And at the same from Dr. Kernu, and Dr. Holbrook asked, is there any evidence that post-COVID sequelae are different from other respiratory viruses other than being very common currently as part of this pandemic? So is there a difference between the post-COVID sequelae from other respiratory viruses? And is there any issue about psychiatric issues?
So in regards to the question about differences between other sequelae of other viral illness, in particular respiratory viruses, so there is a lot of overlap with other coronaviruses like post-SARS and post-MERS that has been found. I think some of the key differences, but it's hard to say whether there is, true concrete evidence, but some of the differences that were highlighted were, one, just the prevalence of these conditions seems to be higher with COVID, though of course that could be related to to a lot of different confounders. And then one of the other differences that I think was noted was just that COVID, as we know in both acute COVID as well, that there seems to be a higher inflammatory response than what we've seen in some other respiratory viruses. And that is thought to contribute to some of the pathophysiology. So some of that prolonged persistent inflammation that we see or we propose to be part of the underlying pathophysiology of long COVID. The other thing was the ACE2 containing organs. Again, I think that is more, those viral reservoirs may be more persistent because of that in COVID specifically.
Thank you, Christina. Dr. Yousuf, did you have another comment? Oh, okay.
Christina.
All right. We have a live question from Dr. Guzman, so I'm just going to activate his ability. Dr. Guzman?
Can you hear me?
Yep.
Okay, perfect. No, just two comments. So first of all, excellent, review of the guidelines. I think it's important that we, are aware of what is going on in the post-pandemic era. So my two comments are the COVID clinic. So we did have an attempt here in Hamilton to develop a COVID clinic. It was done with Dr. Cullen at the rehab center. A couple of us, Dr. Panji, Dr. Sam, Dr. Yousuf, work in this clinic for a little bit. It was a pilot project for 3 months or so, and we saw patients from the region with COVID-19. From my experience, what I think is important is this is a multidisciplinary type of clinic. We have a core GIM. We used to have a core GIM clinic, but also subtype of clinics. We have the cardiac clinic, the autonomic clinic that I run it. We have some rest virologists involved in Point Firestone, and of course the rehab center and the OTPT. And most of those patients, what they require was most likely were more related with rehabilitation, right? So that's the key. Have a good screening type of clinic and develop the subclinics with a rehab component. So I think that's the bottom line from the COVID clinic. Now, from the research perspective, I'm part of the CANCOV and the Reclaim group that are doing studies in Canada. And we recently were approved by CIHR with Dr. Angela Chung in Toronto for studying 4 therapies in 3 therapies actually, with 1 is placebo in long COVID, right? So basically immunotherapy, pentoxifylline, and immunocal, some supplements that increase glutathione levels. But that is something that we're gonna do in Hamilton at some point in the next 6 months. We're gonna develop this clinic that will be linked to the Toronto clinic in order to, assess these patients. Because now what I'm doing is referring those patients to Toronto, because the COVID clinic that we had in Hamilton was just a pilot. The last comment that I have is regarding the autonomic symptoms in COVID. I do see most of these patients in the province with long COVID and cardiac autonomic dysfunction. The bottom line is that it's a small percentage of those patients that actually have actual autonomic failure, autonomic dysfunction. Most of the patients, they have orthostatic intolerance. And I emphasize the importance of doing orthostatic vitals on those patients, because a simple 10 minutes orthostatic standing test can tell you a lot about those symptoms and also about how to target the therapy. This is before you come to our clinic. And I only have seen 1 patient with myocarditis documented with MRI and also with severe autonomic dysfunction, which I presume that is related to small fiber neuropathy. All these things are associated with immune reactions, right? So, and that's what we are seeing now in autonomic dysfunction. In the past, we knew that POTS, autonomic dysfunction, were associated with viruses. Now we have a name for the virus, which is COVID-19. And this is what I agree with Dr. Holbrook in her question, right? So yeah, there should be an association, but I think it's related with immunity. Thank you.
Thanks, Dr. Guzman. We have another question. Dr. Turpie had asked a question, wondering if you can comment on Paxlovid rebound and long COVID.
I'm not sure if Palki or Brian came across it in their reading, but I did try to see if there was any studies done yet. I didn't see any trials. I think there are some trials ongoing to see if Paxlovid can have an effect, but I didn't, sorry. But I don't know anything off the top of my head that I saw in my reading.
Okay. Thank you. Dr. Dorsami has a question. What he's asked is, are there any histopathologic, cytopathologic evidence of persistence of virus in those patients with persistent neurologic sequelae?
Yeah, so there has actually been some evidence shown. So something that I mentioned was they have taken biopsies of intestinal enterocytes with patients with persistent COVID, and has found that there was evidence of like SARS-CoV-2 protein in several of the individuals, but not in all of them. It was sort of, the results weren't consistent throughout. There was also some evidence with bronchoalveolar lavage and some sputum testing that demonstrated some harboring of the virus. But again, it wasn't always consistent throughout all patients and things like that.
Right. Now, Dr. Zandi has asked a question beyond just the biology of the virus, but wanting to know, is there any comments, can patients get long-term disability for their symptoms of long COVID?
I'm actually not too sure about that. I personally haven't had experience with that in patients post-COVID that I've seen. I don't know if Paulky or Christina have had more experience with that.
It's mostly commented on in the context of post-critical illness. So patients that have been in the ICU and have complications from their acute COVID, but there's no evidence right now that we've seen that the actual sort of long COVID symptoms, if they are truly not explained by any other etiology, that they would cause long-term disability. But that's not to say that we won't find that out in the coming years. Dr. Pandya, I also wanted to just address the question, I think Dr. Kern, you had about the psychiatric symptoms. So the NICE guidelines actually do comment on some of the psychiatric symptoms. There are, we didn't really go into this, but the Lancet paper that sort of started talking about long COVID symptoms suggested that it was up to sort of 30% of patients can experience things like anxiety and depression. The NICE guidelines essentially say in patients that are experiencing severe psychosis, which is not common so far, they should be referred to urgent psychiatric assessment. But they don't have much in the way of evidence on how common it is to have severe psychosis requiring hospitalization. The more common sort of presenting psychiatric symptom is anxiety and depression. And they, again, said managing that as you would manage mental health conditions in any other context.
Thank you. So it's 8:57. I just want to say thank you to Paulky, Christina, and Brian. And thank you for Dr. Yousuf for being their Grand Rounds mentor for the topic. This was a wonderful topic. Thank you for answering all the questions. I'm going to end the webinar now. Thank you very much. And everybody, please have a great day.